Hello everyone, today we're going to start our study of the X-ray tube. Today we'll cover in this video the external components and the cathode. So when we talk about medical X-ray units, they can be described as being either diagnostic or therapeutic. In our field we deal with diagnostic units, and we want to keep in mind that diagnostic units operate between 100 to 1200 milliamperes, 0.001 to 10 seconds, and at a peak kilovoltage of about 25 to 150 kVp. Before we move into talking about the tube, we'll talk about some of the external components of the X-ray equipment. First of all, the tabletop. The tabletop is designed to support the patient in a position that will enhance the radiographic position. Some characteristics: the tabletop has to be radiolucent, so X-rays have to pass through it easily. It's usually made out of bakelite or carbon graphite fiber, which is lightweight, radiolucent, but very strong. Most of your tabletops are flat. Some of your fluoroscopy tables have a curved table to them. There has to be a space for a tray to hold the grid and the image receptor. Of course, your table has to be easily cleaned, and it has to be scratch resistant. You don't want to scratch the table, get a little crevice in there, or any body fluids from your patient, or any contrast media, if you're using contrast, would get into those crevices. The radiographic grid and the image receptor tray are incorporated into the table or the upright holder, and of course that's called the bucky or the bucky tray. The grid within the bucky moves during the exposure, and why it moves is to blur out the thin little lead lines that are incorporated into the grid's construction. And remember, your grid within your bucky can either be reciprocating, having a back and forth type of motion, or an oscillating grid, which is more in a somewhat circular motion. Also incorporated into the tray of many of the pieces of equipment are sensors for AEC, or automatic exposure control. Some tabletops don't move, they're stationary. Others move when an electromagnetic lock is released via hand, knee, or a foot switch. Most of your tabletops today, as you know, in being in clinical, are able to move and float. So as I mentioned, tabletops that move are termed floating tabletops. Tables are available in fixed or tilting models. Fixed tables do not permit tilting the patient's head or feet down. Tilting tables are used in RNF rooms, radiography and fluoroscopy rooms. Tilting tables are sometimes described by their tilting capabilities. So for example, a 90-15 indicates a table that tilts 90 degrees in one direction and then 15 degrees in the other. 15 degrees would be the Trendelenburg position. The table is usually at a height that reduces any physical strain on the radiographer, who has to bend and stretch and maneuver in both the patient and the equipment. Remember, if you bring your table down to get your patient on the table, bring the table back up to a comfortable height so that you're not doing a lot of bending and injuring your back. As mentioned, many tables can be lowered to assist the patient in getting on and off the table safely. And remember, very, very important, the patient always needs to be assisted when he or she's getting on or off the radiographic table. I know a lot of techs you see may not do this, but your role as being a conscientious professional technologist is to always have the patient's safety in mind, and we need to make sure that we've got our hand on the patient, assisting them on and off the table so they don't fall. Other types of equipment, of course, some tables, especially in fluoro, have a footboard. These are used on the tilting tables to give the patient a platform to stand on when the table is being tilted upright. Remember, it's critical that the footboard always be checked and tested to see that if it's securely attached to the table. You would not want to not have the locks fitting correctly. The patient is sliding down, standing on the footboard, and as the table's coming up, the footboard falls off and your patient starts to slip. That wouldn't be a good situation. Some of your tables do have shoulder supports. These would be important if you're putting the patient in a Trendelenburg position so that they're not sliding off the top of the table. Many tables also have hand grips. These are attached to the sides of the table. They give the patient an added feeling of security when the table is being raised or lowered. It's a very strange sensation if you've ever been on a table that moves up and down, especially when you're coming upright. It almost feels like you're going to fall forward. So for the patient, especially those that are unsteady, having these hand grips to hold on to gives them assurance that they're not going to fall. Some of your tables, although not many today, we don't use these much anymore, have compression bands. They used to be used for compressing the abdominal tissue for more of an even subject density. However, today, if they are there, they're usually used to restrain uncooperative patients. There are different types of tube supports. We've got the overhead suspension system, which is what is used in most hospital settings. It's sometimes called a ceiling suspension system. It's a good type of system to work with because it allows for a lot of flexibility in positioning the tube. And it has locks that control longitudinal, horizontal, swivel, and vertical positioning. And of course, there are detents or centering locks that lock the tube into place. As far as a floor to ceiling suspension system, it uses a pair of rails, one on the ceiling and then one on the floor for longitudinal positioning. You can see a picture of that over on the right. It does have decreased flexibility in positioning compared to the overhead suspension systems. There are floor suspension systems. These use a tube support column that's mounted on the floor. The system has to be very precisely counterbalanced so that it won't tip over, since it's not attached to the ceiling. Very limited flexibility compared to the overhead suspension system. And then, of course, we've got our mobile systems. Tube suspension is based on the floor suspension model. Basically, if you take a look at the top picture where you've got a column and the tube coming off, it's the same thing for your portable. It's a column with the tube that's going to come off then and can be angled or moved into position. We've got C-arm suspension systems. Utilizes a C-shaped arm to support the tube and image receptor, which are fixed to opposite ends of the C-arm. It can be rotated in various positions to obtain radiographic images. So patient is lying on a table, frequently used in special procedures, in surgery. Patient is lying flat and you're able to get frontal, oblique, or lateral projections, not by moving the patient, but by moving the C-arm itself. And then, of course, you've got your upright units, your upright bucky, common useful ancillary piece of equipment in any radiographic room. Generally, the upright bucky includes all of the components of the table bucky. And it seems today, more often than not, that things that years ago were done more on the table, as far as different projections, a lot of that is being done upright today. And then you've got all kinds of special diagnostic equipment. You've got Panorex units, which of course can be used radiography of the mandible or whole mouth x-rays. radiation therapy simulators used for planning out radiation therapy, mammography units, tomography units for obtaining a linear tomography, and then our computerized tomographic units, our CT machines. Let's move into talking about the tube now. The protective tube housing. We want to keep in mind, if we look at this diagram over on the right, here you've got the tube, and the tube is enclosed in what we term the protective tube housing. We want to also keep in mind, and we can see this from the diagram, that when we create X-rays, the X-rays being created at the anode are emitted what we call isotropically. Remember, isotropically means with an equal intensity in all directions. So when we look at this picture here, we can see the photons are coming off not just where the useful beam would be utilized, but coming off in all different angles. We don't need those rays, so we'd like to contain those. So the tube housing minimizes, it's designed to minimize this leakage radiation, because sometimes photons do get through the housing, and those of course are called leakage. Those are the photons that exit other than at the window of the tube or the port of the housing itself. By law, these tube housings must reduce the amount of leakage to less than 1 milligray per hour at a distance of 1 meter when operated at maximum conditions. That is a fact that you want to make sure that you remember for the registry. Protective tube housings must limit the amount of leakage radiation to 1 milligray per hour at 1 meter. The tube housing also incorporates high voltage receptacles to protect against electric shock. You think about it when you're taking an X-ray, and if we set it up for 120 kVp, what does that mean? 120,000 volts of electricity. So the tube housing has these areas within it that are able to act as receptacles to protect against any electric shock. The tube housing also acts as a mechanical support for the tube itself, and it contains oil, which acts as both a thermal cushion, absorbing a lot of the heat that's being produced, and then an electrical insulator. Remember, we use this dielectric oil that acts as an electrical insulator. And some of your tube housings also have fans built in to aid in cooling as well. When we talk about the X-ray tube, X-ray tubes today are either glass or they're metal, or they're a combination of both. Okay? It allows for the components, the cathode and the anode, to be contained within a vacuum. Remember, to produce X-rays efficiently and effectively, those electrons streaming over from the cathode to the anode, you don't want them to bump into any air molecules, so we need there to be a vacuum. As I just mentioned, the vacuum does allow for more efficient X-ray production and therefore a longer tube life. Metal is being used more often for, as I mentioned, either the whole tube itself or for a part of the tube. Why is metal being used? It maintains a constant electric potential between the electrons of the tube current. Remember, that's the electrons streaming across and the enclosure itself. You get basically then less arcing occurring. So these metal tubes provide for a longer tube life. They're less likely to fail. And almost all high-capacity X-ray tubes today use metal enclosures. Talk a little bit about the cathode. Remember, the cathode, of course, is the negative component of the X-ray tube. If we take a look down at the bottom, you can see in A there is the focusing cup pictured there with your two filaments, small and large, in there. And then in B, we see the components of the X-ray circuit that go along with the filament. Remember, for your filament to select the different MA values, the rheostat or MA selector, which is a variable resistor, is adjusted. And of course, this is then going to feed the electricity into the step down transformer, because remember, you need to heat up the filament. You need a low voltage but a high amperage. Two primary parts of the cathode. You've got the filament and you've got the focusing cup. Two filaments, we call this dual focus tubes, supply separate electron beams. The filaments provide the necessary electrons for X-ray production via thermionic emission. Remember, when we heat up the filament, we're starting to boil off electrons from the filament, and those are the electrons that are going to then stream across the gap between the cathode and the anode. We call this the tube current. Those are the electrons that are going to bombard the anode to create X-rays. And of course, and we'll talk about this in our next unit, how X-rays are created. We'll review that. But remember, when the electrons strike the anode, two processes by which X-rays are created, either Bremsstrahlung or characteristic. We want to keep in mind that the filaments are made out of what we call thoriated tungsten, as opposed to the anode where you've got tungsten rhenium. So the filament is thoriated tungsten. Tungsten metal does vaporize, and it is deposited on the internal components of the glass envelope. Itself, it can lead to arcing, which eventually can lead to then tube failure. Remember, we just saw that if you have metal tubes, that you're less likely to have tube failure because of arcing not occurring. The filament is embedded in a metal negatively charged shroud to confine the electron beam to a small area on the anode. Remember, as these electrons are being boiled off, they need to be kept around the filament until then we apply the kilovoltage to cause them to move then toward the anode. Your book mentions grid control tubes. Grid control tubes are tubes that are used for rapid serial exposures, which means very quickly on and off, like in digital angiography, for example. Now, the grid, though, is not the type of grid that we talk about, grid with lead strips in it, radiolucent strips, and radiopaque strips that confine the scatter radiation. This type of grid in electronics is a switch, basically. It allows for the electricity to quickly go on and off. And in this type of a tube, what we call a grid-controlled tube, the focusing cup actually is the grid. It acts as the switch. You want to keep that in mind. Sometimes you see that question in review books. What acts as the switch in a grid-controlled tube? And it would be the focusing cup. So remember, the importance of the focusing cup is to confine the electrons that are going to eventually form the tube current. We do that by, remember, having the negative charge on the focusing cup. That negative charge kind of repels and pushes those electrons against and keeps them around the filament until they can then be sent over to the anode by setting up a large potential difference or kilovoltage. The electrons themselves around the filament is referred to as the space charge. And we learned this in the past before that. Remember, as you boil off more and more electrons off of that filament, you're getting this very, very strong negative charge around the filament. And eventually it gets such a strong negative field around the filament, it won't even allow any more electrons to be boiled off of the filament. We call this the space charge effect. So if we read, as more and more electrons are boiled off of the filament, the electrostatic repulsion limits further electrons from being boiled off. And it limits tubes to about 1,000 MA, although some authors do say 1,200 MA. So between 1,000 to 1,200 MA Once you get to that point, you've got so many electrons around the filament, no more can be boiled off. That's referred to then as the space charge effect. Small focal spot is used for smaller body parts, providing better detail. And we have to use a large focal spot when we're doing larger body parts where higher techniques are needed, because higher techniques are going to give you more heat. A lot of electrons being confined to a small area of the anode would cause pitting, and you wouldn't want that. So we use a larger focal spot, larger area of bombardment, less likely to pit the anode. So if we read used for large body parts, when needed technique will create large amounts of heat, large amounts of electrons that could pit the anode. The large focal spot is used with techniques requiring 400 MA and higher.